So if there is a misfit and also inability to clean of to these areas, there's another disaster coming to us with like gum disease and terrible gums, and then it goes down and recession, terrible recessions, and terrible aesthetic is coming out. Just like this one too. In the survival wise, perfect, 100%, everything is in the place. But success, right? There's nothing right. Everything is wrong. So there's important words in the literature too. They are always talking about the success, survival rate. Sorry, not the success, survival rate. If the article talking about survival rate, I don't care. I don't read much about it. I look for the success rate all the time. Although there is a lot of criteria involved with the success rate, but always advise you talking about success rate, please. Don't talk about the survival rate. They are the two important words. This is the survival rate is 100% perfect, but it is terrible in the success wise. So the cementation is a growing because they are selling implants to everybody. Everybody is doing the implant. And the problem is growing every day and incredible. Then we talk about the impression because the major problem, taking an impression from the screw retained prosthesis. When you're constructing the screw retained prosthesis, yes, I accept there are some cases you cannot do it with the screw retained. You have to do it by the cement retained prosthesis. But you can 99% produce the screw retained. But this is difficult. You have to be precise. You have to be precise in the impression. But unfortunately, dentistry is something like a science that you have to be always precise. Like, can you imagine, can you correct the surgeon's fault? Surgeon has to be precise too. He has to know where it is going to be placed the implant. So after that, you have to be very precise to taking the impression. So you have to be, your technician has to be precise too, how to build up that crown onto the implant. Then you have to be precise again. How are you going to put that restoration into the mouth? So if there is somebody in the wrong in that chain, the chain doesn't work. A couple of them is maybe perfect, but no, the result will be disaster. So in the literature, look how this is about after 2000, after 2010, there is a lot of impression technique they are talking about. So some companies in the recently, like 2020, 2021, in this year and the last year, they try to find alternatives without cement. What can we do? Like in 2016, Dr. Svoboda, he designed the metal crown, just a gray line in here, just make the edges for the metal edges for the crown. So when the yellow one is the cement, when you put the crown on top, all this excess cement is going to be supposed to be going out of the top of the gingiva. So I'm afraid it didn't work much, but now the manufacturers, the famous ones like Astra and Nobel and ITI, they try to cementless solution. Like they produce that abutment like that on the bottom, on the yellow one, into the implant, and there's a crown like that inside the second primer crown, and then you build up the porcelain crown, and then you fit these three to each other without any cement. They squeeze it in. There is no cement involved in this type of crown. And also Astra, they produce something like that. Again, there is a two-piece. They get into each other primer and the crown and the abutment. They don't use any cement, just they hit and slowly and push the little force, and they put it in the crown inside this primer, and then put the primer to the implant abutment. And then Nobel Biocare tried to make lift up this on one concept, lift up the abutment to the gums level. So they produced a one screw type crown to stabilize on top of the implant. So they're all solution for the single implants. They do not solution for the multiple ones. Probably they will come one day for the multiple ones too, but not today. So what we have a screw type precision prosthesis. So they couldn't find better than that now. So what we're going to do, we have to teach and learn the impression. So we know the impression actually. We take the impression every day for the crown and ordinary crown or ordinary making a complete denture or whatever it is. But for the implant wise, if you're using the multiple implants, you have to make the proper impression, precise impression. So we back to the same problem again. So how are we going to take this impression? So we just a short review for you, the impression, classify the impressions. In implantology, you can take the implant level impression or abutment level impression. If you're taking the abutment level impression, you use some snap-on techniques or multi-unit abutments, or in the top, you will use the abutments that you give to the technician, and technician will prepare for you, and then you use for the cementation most of the time. But we are going to talk about multi-unit abutments today, mostly. And impression is also could be taken closed tray or open tray. Well, I am most of the time here that doesn't matter closed or open. Actually, as a prosthodontist, it does matter. I will advise everyone to use open tray impression, which is more stable than closed tray, although the studies cannot show the differences between them. But minimal differences I will show towards the end of my lecture, how it makes the differences. So what is the affecting the impression? I mean, impression material, snap-on impression, shape of impression post, fitting surface of the impression post, fixation of the posts, or test for the passive fit. How are you going to do that? So Professor Tarnow, in one lecture, he talked about us like the prosthodontist. They are the plumber. Don't be a plumber, be a scientist, he says, which is he's right. So I'm going to explain to you what's going on in a science-wise rather than a plumber-wise, according to his advice. So impression material, very important. There's a good study called Moreira. He does that type of impression materials, position of the implant and angulation, height and shape of the impression post. He searched for that. And he says, of course, we're using additional and polyether impressions for this implantology. He says, if you have angulated implants, use A-silicone. If you have a polyether implant, polyether impression material, use straight implants. So, but there is a small differences, which I prefer the A-silicones because the impression material, thickness of the impression material is so small in the polyether impressions. So I need some bulk, which is hardening well, like A-silicone, additional silicone. And then when I try to put into my postus inside, doesn't flexes anything. Although this gets polyether gets hardened too, but because it is you can use it with the special tray, but it is difficult to replace the posts inside in the impressions. So I always saying that if you're using the polyether, also you must use open tray to take the impression. So they say impression taken if more than implants they suggest open tray. 6 studies suggest open tray. 4 studies, there is no difference between open or closed trays. Impression taken if less than 4 implants. 2 studies suggest open tray. 2 studies, no differences between open and closed. But as I said, we measuring very minor things. Therefore, you cannot find in a millimeters or when you measure it, it's a very sensitive measurement. But I do feel subjectively, I'm saying I cannot tell you the objectively, but definitely there is a minor movement in open or closed trays. Even though you using the snap-on technique. Yes, there is a special things in here, caps there, and then special is prepared abutments. You take the impression and then you sink into the these plastics. Yes, you have a sort of precise impression, but unfortunately, you can't do it more than 4 implants. It has to be parallel to all of them. It is very difficult to do it. So another problem with the closed trays impression, you must have a very sharp edges in the posts. So if you round it, you have a difficulty, which I'll show you in a second. But if you have a sharp edges and long edges, long posts, you will be more successful than round ones. So in here, what we're doing is we take the impression, we will sink into the impression this post. If there's a sharp edges and the curves, then it fits nicely. So that's the small video which I would like to try to show it to you. First, we put the replicas and then place the position which you feel it fits perfect. Even though I'm not very happy, I must say, even though I'm not very happy, because every time you could have a small minor movements, especially if your posts are rounded. Like sometimes in some implant manufacturers, they put in the screw on top of it, and then you putting this post into the implant, and then screw and tighten it, and then you're taking the impression. And there's a small balls like that, it stays inside the impression. And when you take this impression post to seat it into this place, then most of the time you have a problem. It cannot be seated because of that bubble in there. Therefore, they suggest before you take the impression, you put some red wax on it and then create a space in there to make this. This is taking time and this is taking the problem. So if your impression post square, snap, or round, whatever it is, you should have the better one is the always we say sharp ones and the longer ones. Long posts always gives you the good impression. That is the problem. Another problem which has not been mentioned anywhere else, I must tell you today to you, especially, I do some small study on this. Some impression posts, they are very small height, which engage to the implant, like 4 millimeter, 3 millimeter, and 2 millimeter height. This is engaging to the implant. If you have a short engagement, then it's very easy to make a mistake. You think you fitted the impression post to the implant. Unfortunately, no, you didn't. Why I learned from this, we are from our student. There is one type of implants we're using once upon a time in our dental school, and technician and our dental students, they were complaining about it. They cannot take a good impression. So I started to investigate what is going on and what is the problem with that implant. And I found out that it is the 2 millimeter height for the engagement height is not good enough. At least at least has to be 3 or 4 millimeter high to get inside to the implant and fit it properly. That's the proper post, we will call it. So if you are taking an open impression, so what are you going to do? Like, you're going to splint them. If you are splint them, we have been told once upon a time, about 5-6 years ago, they told us, use the dental floss and self-cure acrylic Duralay to fix this fixation, or dental floss or composite or metal or composite. Everybody suggests something. Like, we put some dental floss around the posts, and then we put the Duralay on it. We have been told that it is a no minimum shrinkage in the Duralay. There is no problem. But then I found out we have to section it, because Duralay has a 5% for shrinkage. So this is a quite high to create a stress if our technician make the bar according to this impression. So whatever it is not good. We use metal to fix the implant posts, impression posts. It doesn't work. Then in the articles, Dr. Mutlu Özcan, she suggests that make a frame like that. Make a frame is a fixed frame between the two implants, and then correct it and then fix them with the Duralay, post by post, impression posts, and then take the impression on top of it and create like this type of impression. It is time consuming, and it is a bit expensive, extra cost for the impression. So what I do, I just do my impressions now with the plastic bars I used. And between the impression posts, I use these plastic bars and connect the plastic bars to the impression posts by the Duralay. So I just want to show you the how to I take an impression. I used always the plastic open trays to my patient, and I checked, and everything is fine. And then I try to try to fix that 4 implants using by plastic, and I put some Duralay onto the impression posts. I will show you the one, and then I put the plastic bar within that 2 posts. And then I fix this. Because there is not bulk of it, the Duralay, so there is no effect of the shrinkage. But in the bar, it's correctly stays in between 2 posts, and keep the space stable. And then I do it in the same thing in the other posts. And now it is ready for the impression. And I put the first impression, the second impression to the under the bar, under the plastics. And then a silicone open tray. And then, very important part, expose the tip of the posts because I'm going to unscrew them without any pressure. I will remove the impression from there. So wait to set. Then after set, I will clear the top of the impression post, these particles. Now, without any pressure, without any pulling, without moving, I remove my impression from the mouth. Then I put the replicas into the position to the implants always myself. If there's any mistake or not, I'll have to check it, make sure everything I do perfectly without any macro movement in the between my posts. Then, okay, I took the impression. Is it right or not? Now I have to test for the best fitting. So as I said, everything must be precise. Some people, in the lectures I saw, they teach us like using the plastic like that, and they try to, if the frame is okay or not, before they construct the frame, they try to with the plastics. I will advise you to not to do it, because the plastic is always, when you under the stress, plastic is mobile material. It will be moved right to left everywhere. So whatever you test with this one is perfectly wrong. I'm afraid you have to, I'm sorry, you have to cast your frame right away. Then what you need to do is just check that marking there, and our screw is turning 1, and this is 3, 2, sorry, 3, and then 4 and quarter. So my frame sits in the model, turning around that screw 4 1/4 times. So if I am right, this frame has to fit in the patient's mouth again 4 1/4 times when turned the screw. So this is the coming one. That is the one here. This is 2. This is 3. And that is the quarter. So 1 to 1 is the model and the patient's mouth. And as you see, there is no resistance. I didn't put any pressure on it. Now the screw is fitting perfectly. And after that, I'm going to, of course, not today, after the my porcelain or whatever the material I'm going to use, I use always plastic most of the time, I would say. When they finished our prosthesis, it is going to be fit there 4 1/2. I turn my by hand, then I torque it with my machine in 15 Newton. So try again. This is the different patient. Here is my marking. I'm turning around this time 1, 2, 3, 3 and 3/4 this time. It's turning around and 3 3/4. So let's look at it in the clinic. What's going to happen? Again, that's the marking in my screw. 2, 1, 2, and 3, and turned around, and 3/4 has to be stopped. Here it is. So I checked my precise impression is right or wrong. If it doesn't, you will never able to do it in the same times you turning around that screwdriver. So that is the checked impression, multiple implant situations. So in the conclusion, I will say in the implant impression material is important. I advise to silicone. Snap of impression, yes, fine. Shape of impression posts, again, has to be longer and square one. And then fitting surface is important. Longer the fitting surface is, the better the posts. Splinting is important with using minimum Drolet. And then test the frame, whatever you do, you have to test the frame and passively fitting. As I said, in the dentistry, is it luck or not? I don't know. But whatever you failed, it doesn't come out the problem tomorrow. It comes out about a year or 2 or 3 years later. Because the frame doesn't fit in the passive way, then you're going to have 2 years later, you're going to have a mobile implant. Some implants going to be you losing. Then you try to think about what happened to my implant. Actually, your active frame is always causing the major problems. So it's a happy time for me to share with my knowledge to you. Thanks for your kind attention. And I would like to thank Dr. Ali again, organizing this meeting. Thanks very much to all.
Thank you very much, dear Professor Ender, for your presentation. It was a great pleasure and honor to host you today in this event. Have a nice Sunday. Wish you a nice weekend. I checked the comments. There are no questions right now, so I think everything is clear from your side. Many thanks again. See you soon. Thank you very much.
Thank you very much. Thanks for everybody. Have a nice Sunday. Thank you very much. Bye-bye.
Bye-bye. Bye-bye. And now I would like to say welcome to Professor Cleopatra from Athens, Greece. Good afternoon, Professor Cleopatra.
Good afternoon. Thank you for the invitation.
You are most welcome. It's always my pleasure and honor to host you, to share together new trends and knowledge with all of colleagues from different countries who are watching us right now. Could you please share your screen, then we can see your presentation.
Share screen. I want to 1 second.
No problem.
Share. I might make a mistake. I don't know. 1 second. Why entire screen? Let me see. Share, and no, I don't want to share the entire screen. I want to share only my presentation.
Yes.
So how I do that?
Just click on the presentation on your laptop, okay, and then yes. Now just great.
The screen is 1 second.
Yeah.
1 second. Okay. Here we are.
Yeah.
Okay. Thank you, Ali, Dr. Ali, for the invitation to share with you my knowledge and experience about PRF aesthetics, new trends in aesthetics, and of course, I am going to present my technique, which is Cleopatra technique. I will also announce to all of you that soon we're going to have the conference in Agadir this coming summer. And of course, we're going to organize some courses about facial aesthetics, Cleopatra technique, in order to be able to combine aesthetics and dentistry all together. My motto is stay young with your own blood. And of course, we can achieve that by working not only inside the mouth, but outside and improving the skin quality. Because as I said many times, whatever we do, if we don't improve and fix the perioral area and the face as a total, then our dental work doesn't show as much as when work in combination. Of course, my technique is something very innovative, and you can see that the results, even if you don't do anything on the face, stay more than 2 years. And I will have very soon some photos to show you that even after 3 years and more, the results stay. And even the face becomes better and better. Nowadays, there are a lot of trends in dental industry. We're working digitally. We're using laser. We have the social media to present our work. And why not to add facial aesthetics? This lady came to us for implants, and we couldn't do anything in the upper jaw because she couldn't go through a very big operation, taking bone from the iliac crest. So we put implants in the lower jaw, and we fixed the upper jaw with a vestuloplasty. And of course, we did facial aesthetics, so you can see the result. This was the case when we start the treatment. We put the implants in the lower jaw. Of course, we used PRF, platelet-rich fibrin. This is a very innovative technique. The technique was invented by Joseph Choukroun. For me, he's a person who has changed the history in dentistry and in oral surgery. So we have great respect for his protocols. And of course, I follow his protocol step by step. We do the surgery, we put the implants, we do the osteoplasty, and of course, we add PRF in order to enhance the healing. In the upper jaw, as I said, we couldn't put implants due to the loss of the bone. So we did the vestuloplasty, and at the same time, we added the membranes of PRF. And you see how much we can enhance the healing process. Now here you see the new blood vessel formation, and this is how the case ends up in the upper jaw. So the denture can be more stable. And of course, in the lower jaw, due to the fact that we had a trauma from the denture, that it was stabilized on the upper jaw with a screw in the palatal area. So we can see a trauma here. And of course, we can treat this trauma by PRF in a liquid form. So what do? We inject around the wound in order to promote the healing process. And of course, we can see an acceleration in healing. And this is the case. And you can see the quality of the soft tissue we can achieve using PRF during the surgery and after the surgery in order to promote the healing. And of course, what is the end point for me? This is the most important. This is why we work, all of us worldwide, is to see a big smile and a big happiness from our patients. In this case, I did a minor changes of the perioral area, and you see how much we can improve the face of the patient. This is something similar. We put implants in the lower and in the upper jaw, and of course, we improve the perioral area with Cleopatra technique. And what do we have? Again, a very happy patient. Of course, if we can improve the perioral area, the area of the upper lip, it's very important, because if we can eliminate the wrinkles, we can show our dental work even more. But let's see what is happening as we get older. There are a lot of changes, physical, psychological, and social, that they increase the aging process. So the distribution of the tissue is changing by all these years. So actually, we want to reverse the clock. How can we do that? By eliminating the aging factors. The sun, we have to be very careful. Gravity, there is nothing to do about this, but definitely we can stop smoking. We can decrease the stress. We can pay a lot of attention to the nutrition that we get. Of course, drink a lot of water, eliminate alcohol, and try to change the lifestyle. First of all, if we want to start with the facial aesthetics, we have to go back to the books and to just study about facial anatomy. Because if you have a person who is 20 years old, and if you have a person who is 84 years old, you can see all the changes that they happen from the hair, that they change in color, they become gray. from the distribution of the tissues, the relaxation of the muscles and the ligament, and of course, the bone that is being desorbed through the years. So all these factors are increasing the aging process. And of course, if we want to dive more into facial aesthetics, we have to study the muscle system. We have to study the vascular system and the nervous system, because we inject inside the skin. That means the technique is blind, and we have to be very careful in some areas that there are some great vessels or nerves that we might injure. We have to know the skin, the layers of the skin, and we have to be able to distinguish the older from the younger skin. And of course, we want to reverse the clock by stimulating the fibroblasts in order to produce collagen and elastin. Of course, all the people, all the ethnicities are not the same. So what we do for the skin type 1, we don't do the exact same thing with the skin type 6. So if we want to start doing anti-aging treatments, we have to be able to distinguish the differences between an older and a younger skin. And of course, we should know that as we get older, we lose volume. That means we have less fat, and the fat is melting to the lower parts of the face. We have deep wrinkles. Of course, we have less collagen and elastin fibers, and the skin becomes thinner and drier. And of course, there is no support, so the skin is sagging down. So we see in this slide, as we get older, the fibroblasts are getting lazy. So we have to find a way to make them start working and be awake again in order to produce collagen and elastin. As I said before, nutrition has a very important role in the anti-aging procedure. This is one of the latest publications that we did with Ana Maria Vesala. She's an oral surgeon, and my team. We work with 2 universities, and actually we try to show that a personalized nutrition plan, which is based on the genetic profile, improves the outcomes of facial regeneration with platelet-rich fibrin, liquid matrices, and Cleopatra technique. And actually, what we did, we had patients that they followed a nutrition plan according to the Genosophy test. And of course, these are some of the genes that we can identify. Up to now, we are working with almost 120 genes. And according to what information we get, we can subscribe some supplements for the patients. And of course, we can give them some antioxidants. And of course, we give them a personalized diet plan in order to maximize the results of the treatment. And the new innovation will be from the new year, we're going to add another maybe 100 and even more genes in order to be able to identify who of our patients will have a predisposition of getting older sooner than other people. Of course, we have to pay attention and try to convince people to eliminate smoking. And in order to start talking about all the aesthetic procedures, we have first to invest in the patient, and we have to convince the patient to follow a more healthy lifestyle plan. Now, about the aesthetic procedures, we have 2 kinds. We have the surgical and non-surgical. And of course, the non-surgical is something that we can do as dentists. And we have to go with two ways. The first one is non-autologous, and all the people worldwide, they know the fillers and the Botox. And the autologous way, of course, we have the fat, which gives us the fat adipose stem cells and the blood derivatives. And if we can combine the blood and the fat, we will maximize the results. And of course, our outcome will stay more than 10 years. And Cleopatra technique is an innovative technique which is based in the regenerative medicine. And of course, I am using the protocol of Joseph Soukroun, platelet-rich fibrin. And of course, other blood derivatives have been used for facial aesthetics, mainly PRP. And of course, all these blood derivatives procedures are very safe, non-toxic. They don't cause allergic reactions. And of course, they don't harm the tissues. We're using the stem cells because it's very important to know that with the components of the blood, we have the ability to collect the blood from the patient, put the blood inside a centrifugal machine, and get the platelets, the leukocytes, and the stem cells in order to improve the skin quality. We have the platelet-rich fibrin. This is a next generation. This is the newest protocol of the platelet concentrates. And of course, we have the fibrin matrix, which is composed of these regenerative cells in order to improve the quality of the skin and cause the vascularization of the skin. Our protocol, my protocol, is based on the low-speed centrifugation concept. We're using less G-force in order to save more cells. So now the platelet-rich fibrin is injectable, and it's full of white cells in order to promote the skin healing. So Cleopatra technique is using these tubes. These tubes are medical tubes. They're totally sterilized. They are 13 ml. And we can see by using the IPRF is superior than a platelet-rich plasma because it stimulates a greater dermal skin fibroblast cell migration, proliferation, and collagen synthesis. And of course, this is being seen in all the clinical cases that you're going to see when I will present my clinical cases. We can get more collagen type 1, but if we have to rejuvenate older people, we need more collagen. So we have to find a way to increase the fibrinogen. And by doing this, we get the APRF liquid, which is a biological product in order to fill up the wrinkles. So right now, there is a scientific evidence that we can get tissue regeneration, and we have new angiogenesis. Why? Because we have inflammatory cells, we have growth factors, we have the liquid fibrin and the stem cells. So Cleopatra technique is using both IPRF plus and APRF liquid. And as the idea came was that we traumatize the skin, and of course, we can add PRF liquid, either IPRF plus or APRF liquid, and all together will both produce, stimulate the healing of the tissue because we have the fibroblasts that they get traumatized, and from the trauma, they regenerate and they produce more collagen and elastin. So Cleopatra technique is a well-tolerated and effective method of lower facial rejuvenation that deserves further attention for dentists and other health professionals who utilize conservative methods in facial aesthetics. The procedure is very simple. First of all, we have to prepare the skin. We can use anesthesia as an ointment. The name is EMLA 5%, or local, and in some cases, nerve block anesthesia, in order to reduce the pain. We have to have these tubes, the 13 ml tubes, some syringes, and different kinds of needles or cannulas in order to inject the Cleopatra technique PRF inside the skin. Now about the skin rejuvenation, we know that when we traumatize the skin will rejuvenate. And we can do this with multiple ways by using a Dermapen, using our syringes and needle, and of course, a derma roller. The first way and the easiest way to start with is the microneedling with a Dermapen. And of course, what we do, we traumatize the skin and we are using the Dermapen in order to be able to facilitate the penetration of PRF inside the skin. We can do this with the IPRF Plus, or we can combine IPRF Plus with hyaluronic acid. The other technique is point by point or micropapular technique. And this is an easy way to inject the combination PRF liquid Cleopatra technique inside the skin by using a very tiny needle and creating a microtrauma inside the skin. And of course, we can do it very safely without having the fear of occluding any artery. This is a very simple procedure. We can inject from the skin towards the vermilion. And by using these short needles, we're totally safe. There are a lot of techniques in order to be able to repair the profile, to increase the projection, and to give augmentation to the lips. And of course, in some cases, we can do combination treatment, like in this lady that we did her neck. We did some micropapular technique to rejuvenate the skin of the neck. And when we finished, we did the microneedling with the Dermapen. But when we have older people and we have multiple problems that we want to fix, like the contouring of the lips and the face, acne scars, keloids, eliminate the wrinkles, then the things are getting more difficult. In these cases, definitely we have to use IPRF Plus and APRF liquid, and we can inject inside the skin. The procedure is very simple, and we're using different kinds of needles, and we apply PRF inside the skin. In some more challenging cases, we can use cannulas. Cannulas are needles that they don't traumatize inside of the skin. We're using a bigger size needle, and then we penetrate inside the skin, and at the same time, we are applying PRF liquid, the combination Cleopatra technique. We can use the same procedure to rejuvenate the area of the forehead. Is totally safe. We're using shorter and more narrow needles, and we can apply this in order to eliminate the wrinkles. We can work on the neck area as well. And you see, we create some blebs. We go at the superficial dermis, and we move from one side to the other in order to decrease the pain. These patients, usually, they don't have any problem using EMLA ointment. We can rejuvenate the lips. This is a longer size needle. And again, we go from the skin to the vermilion, and we are increasing the volume of the lips. And of course, we can fix the philtrum and do the contouring of the lips as well. Now, the protocol is very easy. If we are working more superficially, we do one treatment every 15 days. When we work more aggressively, we can do the treatment every 3 to 4 weeks. And we do 3 to 4 sessions in total. And of course, you understand, younger people may need less treatments. Post-treatment, it's easy. We can either give our patients some ice, which I avoid, but if you don't have anything else, you can reduce the edema, or we can use some face mask, or we can put the patient underneath the low-level lead therapy. The mask is very important if you want to follow this protocol, because it has hyaluronic acid and vitamins and peptides. And by putting this, you can reduce the edema and the redness, so the patient can leave the clinic and go to work and follow the daily program. As an aftercare, we always tell the patient to avoid the sun exposure and avoid any heavy exercise for 24 hours. Use always sun protection cream, and they have to reapply the cream 3 times a day. If they have any bruises, they can use the arnica ointment. And according to how much trauma we do on the face, they can use Bepanthol or panthenol cream, which is a hydrating cream, 3-4 times a day for at least 2 to 3 weeks. Now, a lot of people are asking me about the maintenance. This Cleopatra technique is a customized treatment. That means we use the blood of each one of the patients. So there is no formula for all of them. But in general, according to the condition of the skin, the age of the patient, the demands of the patient, the physical condition of the patient, and the lifestyle of the patient, usually we repeat the treatment once or twice a year. But most of the times, the patients are coming to us to do a treatment in order to remain the good results or even improve them. Some clinical cases, you see what we can achieve with Cleopatra technique. This is a totally natural way without the use of any artificial products. And of course, we can increase the projection, the shape, and the volume of the lips, not only in young people, but in older people as well. If the demands are higher, we can increase we can add hyaluronic acid in order to increase the results. This is a case that it was done only with Cleopatra technique without any artificial products, and we can see the rejuvenation of the skin and, of course, the elimination of the wrinkles of the forehead and around the eye area. And of course, if you believe in something, you have to try these treatments for yourself. These are the results of 4 treatments. And we see more cases that we can eliminate the melasma, and we can give a more fullness and pleasant appearance to the face. This is a case that I did Botox for this lady, and she had a lot of problems with pigmentation. 4 months after, we start doing my technique, and you see the results. Of course, if there is hyperpigmentation, we have to make sure that we protect the skin from the sun. And as I said before, in more challenging cases, we have to add hyaluronic acid. This is a case that I did only with the blood, and you see how we started and how we ended up 2 years after. But this lady wanted to improve the results more. So we did Cleopatra Technique Plus. We added some hyaluronic acid. We did the treatment at the same time. And this is how the patient is changing. And this is the end point of a happy patient with nice dentition and nice quality skin. A lot of you are asking me about the combination treatments. Yes, when there is trauma, you can use PRF in order to enhance the healing process. Of course, if you can combine the fat with PRF, definitely you are going to have more stable results for over 10 years. And of course, you are going to reduce the absorption of the fat that you have put in some certain areas of the face. These cases are being done from Dr. Brazzini from Nice. In some cases that we might have complications due to fillers, like in this study that we did with Professor Ganati. This is a case of a 2 years follow-up. This lady had put hyaluronic acid in the temporal area. She got a big infection. It was surgically excised, and then the skin was treated with IPRF Plus for 2 years, and this is what we can achieve only with PRF. We can use it for wound healing, as in this case, that this lady had a big burn on her breast. We used the liquid PRF and the gels. We covered the area with some plastic in order to keep the hydration. And these are the 2 photos that the patient sent to me after 2 days because she was afraid to leave it on the breast for longer time. And you see what is happening in 2 months later. So of course, PRF is something which is very powerful, and if you know exactly how to use it, the results are going to be amazing. We can use it for hair treatment. We can combine with some medicine or some cocktails in order to rejuvenate the hair, and the results are very promising. You can see that we can get some hair regrowth, and of course, we can rejuvenate the hair bulk, because as we get older, the hair are getting thin and they lose vascularization. So IPRF Plus is the ideal biological product for that. We can treat the arthritis, like in this case, Joseph Shukroun is doing some injection in the knee, and we're using IPRF Plus. We disinfect the area and we put the product, the biological product of 2 tubes in one knee, approximately 6 ml of IPRF Plus. And of course, we can repeat this treatment as many times as we need in order to reduce the pain. And of course, we can use it for arthritis on the hands. A lot of people have numbness and pain, so we can increase the mobility of the fingers and we can reduce the pain. These are the results we can get by restoring the vascularization of the joints. For you that you want to keep in touch with me, you can send me an invitation in my Instagram. It's Cleopatra_Nakopoulos. And of course, on Facebook, I have 2 profiles, Cleopatra Chris Nakopoulos and Cleopatra Nakopoulos. I have 2 pages that you can like and see some of the cases I do, or some information about facial aesthetics. Is Cleopatra Technique for Aesthetics and Cleopatra Technique for Aesthetics 2. And also I have 2 personal groups, is WAPS Aesthetica. You can become a member and you can add your friends in order to become members. It's totally free. And the second group is Aesthetica by Cleopatra Nakopoulos. I present my cases and you see the cases of other colleagues. I also do some courses in my clinic in Athens, Greece. Dr. Ali and I are going to organize some courses either in Greece or in Libya or Morocco. And if you want, just send us a message and we are going to get back to you. And thank you very much for your kind attention. We have, as women, a lot of groups, and we're trying to promote things in dentistry, and not only. We have women in dentistry, leading ladies in dentistry, and all of us are going to show to you our work. We're going to share with you innovative things, and all together we can go a step ahead. Thank you very much, and I wish to all of you to have a wonderful weekend.
Thank you very much, dear Professor Cleopatra, for your nice presentation. As you already mentioned, that we planning in the further future, we are going to organize some courses in the field of aesthetic dentistry as well as implant dentistry. And we will announce that regularly. Next meeting going to be in Agadir next summer, 10-11 June 2022 at Universiapolis International University of Agadir Conference Center. Many thanks again, Professor Cleopatra. It was a great honor and pleasure. Outstanding as usual. I enjoyed your presentation. Wish you a great Sunday.
The same to you. Thank you. Thank you.
Bye-bye.
Greetings from Athens, Greece. Bye.
Bye-bye. Thank you. Bye. Take
Bye.
care.
Bye.
And now I would like to say welcome to Professor Angelo Cardarelli from Italy. Welcome, Professor Angelo.
Hello, good morning, my friend. How are you? Thanks again for the invitation. And good morning, everyone.
I'm fine. Thank you very much, my friend. It's my pleasure and honor always to host you in such great events. Along 3 days, we enjoyed many presentations from different colleagues from different countries. I believe that such events increase our connection to share our knowledge, our experience, either based on literature, scientific, or also or our clinical or daily practice. So now the screen and time is yours. Professor Cardarelli, you can start. Thank you. Good luck.
Thank you very much again, and good morning, everyone. Before I start, I'd like to thank you for the invitation, and as usual, your event is always perfect, and I think it's very important in order to increase the knowledge about different topics in oral surgery, in implant surgery. So today I want to share the treatment of the aesthetic zone with the immediate implants and GBR procedure. This is a challenging technique. This is a challenging procedure in order to obtain a good result in terms of the aesthetic and function for our patients, especially for young patients. And obviously, it's very important to follow the right protocol in order to obtain a better outcomes, especially in the aesthetic zone. As we know, in order to place the implants in the edentulous site, we need to have some requirements. A good thickness of bone, a good thickness of the soft tissue, a good quality of soft tissue. Because it's very important to manage the soft tissue around the implants in order to prevent the mucositis and perimplantitis in the years later, during the healing and during the stabilization of the implant. So the management of the soft tissue, as I will show later, is absolutely mandatory in order to maintain, in order to obtain a good healing for a long-term survival. And also is very important to have a good intermaxillary relationship for the prosthetic reason. So, in the aesthetic zone, we need to place the implants following the correct 3D dimension, as you can see from this picture, in order to follow the distance between the dental elements, as you can see, and the distance between the implant surface and the buccal bone. Because as we know, after tooth extraction, we will have an important bone resorption in the first 6 months, especially in the buccal side. For this reason, it's very important to place correctly the implants, following this distance. And as I will show later, it's very important to fill the gap between the implant surface and the buccal bone with the heterolog bone, for example, bovine bone, for the aesthetic reason, in order to maintain the volume. So, for example, if I need to remove a central incisor after the fracture of the root, I can remove these dental elements, I can place immediately the implant, and I can perform the immediate restoration in order to obtain this final aesthetic result, as you can see, with a good healing and a nice shape of the soft tissue around the final crown, screwed crown. But it's very important regarding this case to see this CBCT reconstruction in order to understand better how I can manage the post-extractive site in the aesthetic zone. This is the situation at the beginning. So in this case, I need to remove this compromised central incisor, but after tooth extraction, I need to change this direction following the palatal bone side, according to the right protocol, as you can see from this CBCT reconstruction after the osseointegration of this implant on the central incisor side. And it's very important to have at least 2 or 3 millimeters on the bone in the buccal side in order to prevent the gamma recession, in order to obtain a good osseointegration and a good stability for a long-term survival. So don't forget this image. This is the correct management of the post-extractive site in the aesthetic zone, following always the palatal bone side. And as I said before, the 3D implant placement is absolutely mandatory in order to obtain a good vascularization between the implants, and especially in order to obtain a good healing, in order to obtain a good papilla shape between the implants and the dental elements. So, according to this protocol, as we know, we need to have at least 3 millimeters of distance between the implants and 1.5 millimeters of distance between the dental elements and the implants in order to obtain a good soft tissue shape and a good vascularization around the implants. So don't forget these things and this concept. And also, obviously, we need to check the health of the patient. We need to manage the systemic disease. We need to control the periodontal disease. It's very important in order to have a good result after implant placement, after the prosthetic rehabilitation. So after tooth extraction, it's possible to have 3 different scenarios, as you can see. It's possible to have a favorable situation with intact socket, so we have the preservation of the bone and the soft tissue. It's possible to have a dehiscence of the bone, but we have a good soft tissue shape around this socket, and we can have a challenging situation in which we have a bone and soft tissue dehiscence. So this is a very challenging case. The thickness of the buccal bone site is very important. As you can see from this publication, in fact, if we have a very thin bone tissue in the buccal site, very thin bone phenotype tissue, after 8 weeks later, we will have a complete bone resorption on the buccal side. Instead, if we have a thin bone tissue phenotype, as you can see, after the extraction, after 8 weeks later, we will have a little bit bone resorption. So the thickness of the buccal bone is absolutely mandatory in the management of the aesthetic zone area. And again, have a look at this histological result. If we have less of 1.5 millimeter of thickness in the buccal side, we will have an important bone resorption, as you can see from this histological view, after implant placement. Instead, if we have more than 1.5 millimeter of bone thickness, we will have a better result. We will have not bone resorption in the buccal side. And according to the literature study, in a lot of patients, we have less than 1 millimeter in terms of the buccal bone thickness. So absolutely, we need to manage this clinical condition with a good implant placement following the palatal on the lingual bone side and a good management of the soft tissue. And this is the healing process after tooth extraction, from the extraction time until 4 months later. So if we have a space-making defect, with a preservation of the cortical walls, it's possible to have a self-regeneration with a stabilization of the blood clots. This is a favorable situation. And also, as I said before, is very important the quality and the thickness of the soft tissue. If you pay attention at this publication, the initial thickness of the soft tissue can influence the crystal bone change and the crystal bone resorption. As you can see, if we have a very thin tissue, less than 2 millimeter, after 1 year, we will have a 1.17 millimeter of bone resorption. Instead, if we have a thick tissue more than 2 millimeter in terms of the soft tissue thickness, after 1 year, we will have only 0.21 millimeter in terms of the buccal bone resorption. So the management of the soft tissue is absolutely mandatory. And if we have not sufficient thickness during the immediate implant placement after tooth extraction, we can increase at the same time the thickness of the soft tissue from using the connective tissue from the palate. Exactly like this. So I can remove the premolar, I can place the implant following always the palatal procedure. I can fill the gap between the implant surface and the buccal bone using the heterolog bone for the aesthetic reason in order to maintain the volume, and at the same time I can increase the thickness of the soft tissue using the connective tissue harvested from the palate. This is the best choice in the management of the soft tissue in the post-extractive implant placement, especially in the aesthetic zone, for a long-term stability and for the aesthetic reason. Have a look at this case regarding the treatment of the central incisor with immediate implant placement, with immediate restoration also. Sorry. So it's very important to perform an atraumatic extraction in order to preserve the buccal bone site, as I said before. And after that, following the palatal bone, I can place the implant, following always the parallelism and the correct inclination for the prosthetic reason. And after that, I can place the implant with high primary stability in order to perform the immediate restoration. And as you can see, at the same time, in this case, we have a sufficient keratinized tissue. The thickness of this tissue is more than 2 millimeters. So in this case, I can use only the heterolog bone in order to fill the gap between the implants and the buccal side, exactly like this, using the bovine bone. And at the same time, I can perform the immediate restoration like this, screw at the crown, but it's very important to see the CBCT immediately post-op. So this is the situation at the beginning with the residual root on the central incisor, and as I said before, I need to change this position during the implant placement exactly like this, following the palatal bone site in order to have more than 2 or 3 millimeters in the buccal bone site, exactly like this. And this is the immediate restoration few hours later. So with the immediate restoration, I can obtain an immediate aesthetic without occlusal loading, obviously, and also with this crown, screwed crown, I can manage immediately the shape of the soft tissue. I can maintain the volume and the shape of the soft tissue using the screwed crown, retained. So for this reason, it's very important to use a nice contour of this temporary restoration, because through this temporary restoration, I can obtain a good healing in terms of the host integration, but especially in terms of the soft tissue healing. And in the aesthetic zone, it's absolutely necessary to obtain the better aesthetic result. Obviously, in some cases, in the young patient, if we have a sufficient thickness, we can perform also the flapless procedure using, for example, the surgical guide, as you can see from this case. So using a dedicated surgical guide, I can place the implant on the lateral incisor, following always the palatal approach with the flapless approach, and also in this case, I did the immediate restoration. So it's absolutely mandatory to have a high primary stability. And as usual, I performed the immediate restoration using the screw at the crown retained, as you can see, in order to manage immediately the shape of the soft tissue. So we have different options, but it's very important to follow always the correct protocol. And which are the contraindications in the management of the post-extractive implant site? For example, the buccal bone fenestration is not the contraindication, because I can manage this fenestration using the collagen membrane, for example. the thin tissue phenotype is not a contraindication because, as I showed and as I said before, I can change this phenotype. I can increase the thickness of the soft tissue using the connective tissue harvested from the palate. Also, the acute infection is not a contraindication because I can prescribe the antibiotics therapy 3 or 4 days before the surgery, and I can shift this acute in the chronic infection, and I can place the implant. So these are not the contraindication in immediate implant placement in the aesthetic zone. And now I will show some clinical cases regarding this procedure. We have in this case, a fracture of the lateral incisor. So absolutely, I need to remove this root, but it's very important to see the X-ray before and the CBCT reconstruction in order to understand better the position of the dental elements and the thickness of the residual bone area. So, as I said before, in this case, I need to change the direction of the implant placement following the palatal bone site. Like this. As usual, I perform always the atraumatic extraction. So in this case, we have an acute infection with a periapical lesion. So I need to remove the inflammatory tissue. And after that, I can use, for example, the temporary restoration in order to guide the implant placement following always the palatal placement. After that, absolutely, I need to see the inclination and the position of the implant using the pin. Only after that, I can go ahead with the next drills. But this phase is absolutely necessary in order to place the implant correctly, according to the final prosthetic temporary crown. So I can go ahead with the next drill in order to under-prepare the implant site for the primary stability reason. This is the next drill, and after that I can place the implant 3.75 of diameter and 13 of length with high primary stability. This is the implant placement, and now we have more 2 or 3 millimeters of distance between the implant surface and the buccal bone site. So I need to fill this gap absolutely in order to maintain this bone volume using the bovine bone. Like this, for the aesthetic reason only. And as usual, I did the immediate restoration with the temporary screwed crown. Like this. Good shape, a good contour of this temporary restoration. And now, have a look at the CBCT after implant placement. So, following the palatal bone site, I can have more than 2 millimeters of the buccal bone site. This is the correct implant placement, following always the protocol. And the situation after the surgery, the healing 3 weeks later. So after the osseointegration, 3 months later, this is the situation with a good healing, considering also the periodontal disease that we have in this particular patient. But anyway, we have a good result, a good bone volume and soft tissue maintenance, as you can see. So I took the impression with the intraoral scanner as usual. And this is the final screwed crown, like this. screwed. This is the good placement according to the protocol. It's very important to have a good shape of the final crown in order to maintain, in order to support the soft tissue. And this is the final restoration. Fixed like this. Obviously, in some cases, it's not possible to place the implant at the same time if we have an important bone resorption in the buccal bone site. So, in this case, for example, I need to maintain the bone volume. I need to fill the cavity with the heterolog bone using the collagen membrane, and I need to wait 6 or 8 months, and after that I can place the implant, as you can see from this case, for example. This is another case regarding always the aesthetic area. We have this situation with the fracture of the central incisor, so I decided to remove the root, and the atraumatic extraction is always the best choice. This is the occlusal view, so I can remove the vestibular part of this root and the palatal part. But in this case, we have a complete bone resorption in the buccal side. So I decide to use the connective tissue from the palate in order to increase the keratinized tissue. So I harvested from the posterior side the epithelium connective graft, and the thickness of this connective tissue is 2 millimeters, as you can see. This is the thickness of this connective graft. And after that, obviously, I need to remove the epithelium using the blade. Like this. This is the thickness of the connective graft. And now I need absolutely to remove the epithelium tissue like this, using the blade. And only after that I can use and I can fix the connective tissue like this, using the sutures, obviously. And I use also the collagen membrane in the buccal side. And this is the CBCT reconstruction after the socket preservation procedure. So this is another option if we have not a buccal bone site. And in this case, I used the temporary Maryland restoration, and this is the healing of the soft tissue 3 weeks later. And this is the occlusal view and a good healing of soft tissue. In some cases, for example, we need to remove the impacted dental elements before the implant placement, as you can see from this challenging case in which the patient had double impacted canine and the suranumerary teeth. So in this case, we need to remove both impacted canine, as you can see, on the right and the left side. This is the residual cavity, and after 6 months later, I can place the implants exactly like this. And this is the final restoration. This is the situation before the extraction and after implant placement with a new soft tissue shape. This is the soft tissue shape before and the new shape after implant placement with a good management of soft tissue. and the situation before and after, with a good healing and a good result. And the X-ray post-op. So the situation before and after implants, prosthetic rehabilitation. So the use of the bovine bone is absolutely mandatory in order to maintain the volume. Obviously, we have a different type of materials, and the best choice is always the autologous bone. But obviously, in some cases, especially in the aesthetic zone, frequently we have not the opportunity to harvest the autologous bones in different parts of the oral cavity, also in order to reduce the invasivity. So a good alternative to the autologous bone is obviously the bovine bone, in order to maintain the bone volume, in order to avoid the bone and the soft tissue resorption. And in the aesthetic area, it's absolutely mandatory to have a good aesthetic analysis to check the relationship between the lips and the teeth, to check the phonetic, to check the function, to check the shape of the dental element, to check the age of the patient. So, according to the protocol, it's absolutely mandatory to have a good photographic documentation before, during, and after the treatment, a short video in order to check, in order to understand better the phonetic analysis, the relationship between the dental elements and the lips, in order to understand better the shape of the lips, the shape of the face, in order to have a good selection of the final dental elements. So our goal, as I said before, is always the final aesthetic result, especially in the young patient and especially in the aesthetic zone. So we need to see the different shape of the dental elements, the proportion, in order to obtain a good aesthetic result. The tooth proportion between the length and the weight of the dental elements. The relationship of dental midline to the facial midline. And this relationship should be within 4 millimeters for the aesthetic reason. And also it's possible to have a different smiles shape, low, medium, and highly pline. But fortunately, in 69% of our cases, we have a medium lip line. The high lip line is a very challenging case. And also is very important to see and to understand better the exposure of the soft tissue in the smile and in the rest position for the aesthetic reason, as I said before. And now I want to share this case regarding the patient in which we have this clinical situation at the beginning of our therapy. This is the intraoral view, so we have all the restoration and we have a fracture of the central upper incisor, as you can see from this X-ray. So I need to remove this central incisor. I need to change this old restoration and placing a new, using the implants for the new smile. This is the prosthetic procedure, the choice of the choice colors and the phonetic analysis before the treatment, as you can see. in order to understand better the relationship and the dimensions of the dental element. As I said before, I can use the digital smile design in order to change, in order to increase the dimension of the dental elements like this. This is the virtual plan. I can increase, and I need to increase the length of the central incisor in order to have a good smile line. And from the 3D virtual plan, I can obtain the wax-up procedure like this. And I can use the mock-up directly in the cavity of the patient. This is the temporary mock-up procedure. And according with the patient, at this time, we can decide to change some details. And only after that, only after the mock-up procedure, we can go ahead with the temporary restoration. So this is the situation before and after the mock-up procedure, the lateral view after the mock-up procedure, and the videos before and after. This is the new smile, the preview of the final aesthetic result. Only after this procedure and this phase, we can go ahead with the surgical procedure and the prosthetic procedure. So the phonetic analysis is very, very important. And from the mock-up procedure, I can obtain the temporary crowns exactly like this, and I can go ahead with the surgical procedure with the implant placement on the right and the left side, like this, and on the central incisor. So I removed the central incisors as usual with an atraumatic extraction. This is the fracture of this central incisor. And following the protocol, following the palatal bone aspect, I can prepare the apex of this new alveolar site at least 3 millimeters in order to obtain a good primary stability. As you can see, this is the immediate implant placement. In this case, we have not distance between the implant and the bone, and we have a very thick bone. So in this case, I didn't use the heterolog bone, but I used the temporary restoration with a good contour in order to obtain a good soft tissue shape, in order to stabilize, in order to obtain the stabilization of the blood clot, like this. And this is the view after temporary crowns restoration, before mock-up and immediate restoration. After 4 months, I can take the impression for the temporary crowns on the implants like this, and this is the final restoration. And this is an amazing healing on the central incisors. And I prepared the natural dental elements for the veneers and for the final crown. This is the healing with the different view, and this is the final screwed crown. And this is the final view. With a good healing and a good osseointegration. But we have a very nice result on the central incisor in terms of the shape, in terms of the quality of the soft tissue. as you can see. And this is the X-ray post-op, the final X-rays, and the comparison between the initial situation and the final restoration. And now I would like to share the last challenging case regarding the young patient in which we have an infection of the central incisor, as you can see. And if you pay attention from the CBCT scan, we have a huge lesion on the central incisor for the previous failed endodontic treatment. So it's not possible to keep this central incisor. So I decided to remove it, performing the endodontic surgery on the lateral incisor and filling the residual cavity with the bovine bone in order to maintain the bone volume, and I performed the interrupted suture and the temporary restoration with the Maryland restoration. But it's very interesting to see the healing after 6 months. Good healing. This is the CBCT reconstruction, but it's very interesting to see the healing of the soft tissue in this area. So now I can place the implant, and in order to reduce the invasivity, in order to maintain the bone volume, I prepared using a very minimal flap, the book flap design, as you can see, manual implant site preparation, like this, and I placed the 3.8 millimeter in terms of the diameter and 13 of length, and this is the CBCT reconstruction. So we have 3 millimeter, more than 3 millimeter on the buccal side, and this is the X-ray immediate post. So after 3 months later, I can take the impression for the temporary crown, and after 1 month later, I can do the final restoration with zirconium abutment, and this is the final view with a good healing and a good thickness of the soft tissue, and this is the X-ray post-op. So this is a very challenging case, but if I follow the protocol, I can obtain a good result, and this is the follow-up of this patient, of this clinical case, 4 years later. So at the end of this lecture, I would like to remind you some concepts, some things about this procedure. We need to reduce the invasivity during the extraction. We need to place the implants in this area with a good 3D implant placement. In the post-extractive area, it's better to place the implant below the bone, 0.5 millimeter to 1.5 millimeter. If necessary, we need to increase the soft tissue. And absolutely is very important to use a good control of the temporary restoration, and I would like to suggest in the implant restoration, the use always the screwed retained restoration. Because with the screwed retained crown, we can reduce the micro movement because we have only one piece, and also we can reduce the risk of the inflammation, the risk of the mucositis and periimplantitis, because with the screwed crown restoration, we will have not the cementum during the prosthetic procedure. So, thank you for your kind attention, and if you have any question, please feel free. Thanks again, and I hope everything was clear.
Thank you very much, dear Professor Angelo, for this nice presentation. Scientific, high-level scientific evidence based with clinical cases, outstanding as usual.
Thank you. Thank you.
I don't know if there is any question in the comments right now. No. So now it's the time to see. Thank you very much to all of our speakers from the first day until today. We finishing with you, Professor Angelo. I wish you great Sunday. Please take a rest
Thank you.
to start the new week with full of energy, and looking forward to seeing you soon.
Absolutely. Absolutely.
Thank you very much to all of our participants, audience who were with us from the first day until today. I hope that everything was as you expected. Looking forward to share another events, courses with all of you in next future. Thank you very much to all of you. Goodbye. Take care.
Thank you, everyone, and I hope to see you soon, face to face, for next course together.
Yes, sure. Thank you very much, Professor Angelo. Thank you.
Thank you again. Congratulations
Bye-bye.
for this event.
Thank you. Thank you. Thank you. So kind of you. Thank you. So, thank you, everybody, for your attention along these 3 days. I hope that everything was as you expected. I have as already said. Looking forward for another events in next months or next future. Thank you very much. Take care. Goodbye.